If a patient hits the emergency department doors actively seizing, textbook neurology says you follow a pretty strict linear protocol.
Right, the standard algorithm.
Exactly. You give a first-line agent, you wait a specific number of minutes, move to second line, and ideally, the electrical storm in the brain just, subsides.
Yeah, you're treating it almost like well, like a localized short circuit in the brain's wiring.
But, and this is a massive but, if that seizure is caused by a massive chemical invasion like a toxin or severe withdrawal, following that standard textbook protocol could literally kill the patient.
Oh, absolutely. The rules of emergency neurology just completely break down in the face of a toxicological storm.
Because the paradigm shifts entirely, right?
Yeah, I mean, the underlying pathology is totally different. With a standard epileptic seizure, you're usually dealing with a structural abnormality, like a scar, or just an inherent threshold issue in a specific neural network.
Right.
But with a toxic seizure, the brain is effectively the battlefield, and a systemic poison is this invading army. The entire neurochemical environment has been hijacked.
And today, for you, the perpetually curious learner, we are unpacking exactly why that clinical shift is so difficult to manage.
It really forces physicians to rethink their muscle memory.
Definitely. So if you're the type of listener who wants to know the actual, pharmacological mechanics behind these high-stakes critical care decisions, you're in the right place.
We've got a really solid stack of literature to go through today, too.
We do. We're integrating standard guidelines, a pivotal 2018 retrospective study by Lee and colleagues, the 2022 post-hoc analysis of the ESETT trial by Corellick and team, and some incredibly sharp critiques from toxicology experts like Baumgartner regarding how we actually dose these patients.
Yeah, the Baumgartner critique is it's fascinating because it highlights the friction between general ER algorithms and specialized medical toxicology.
Okay, let's unpack this. Let's start right at the point of contact.
The very beginning.
Right. When that toxicological seizure begins, regardless of the specific poison involved, the universally accepted first-line response is the administration of benzodiazepines.
Yes, the undisputed first line.
We hear about BZDs constantly, but looking at the cellular level, they aren't actually stopping the seizure on their own, are they?
No, they aren't. And that's a crucial distinction. Benzodiazepines do not act as direct agonists.
They don't just replace GABA.
Exactly. GABA is the brain's primary inhibitory neurotransmitter. BZDs don't replace it. They act as positive allosteric modulators.
At the synaptic GABA receptors.
Right. They bind to a specific accessory site, an allosteric site on the receptor complex, and when they bind, they induce a physical change in the receptor that vastly increases its affinity for the endogenous GABA that is already floating around in the synapse.
Okay, so think of GABA as the bouncer at a chaotic club. BZDs don't add more bouncers. They just give that bouncer a massive megaphone to calm the crowd down.
I love that analogy. It perfectly explains how they increase the frequency of the doors opening to let the pressure out.
Right, allowing that influx of negatively charged chloride ions into the neuron to cool down the electrical activity.
Yeah, the BZDs make the system hyper-responsive. But the real challenge in toxicology is the time constraint.
There's a biological clock ticking, right?
A very rigid one. It starts the exact moment a seizure begins. If you don't achieve control within roughly 30 minutes, benzodiazepines lose a massive portion of their efficacy.
Wait, really? Just 30 minutes? Is the drug just metabolizing too fast?
No, it's not the metabolism at all. It's actually the brain dynamically altering its own architecture. The synapses literally internalize those GABA-A receptors.
Through endocytosis.
Exactly. The brain is highly adaptive. During prolonged status epilepticus, the continuous violent electrical firing causes the postsynaptic membrane to essentially swallow its own GABA-A receptors.
Oh, wow. So they're pulled from the surface into the interior of the cell.
Yeah, so you could saturate the patient's bloodstream with massive doses of DZDs, but if the receptors aren't on the surface, the drug literally has nothing to bind to.
Which means aggressive, immediate treatment is just absolutely paramount.
It's the only way.
And that brings us directly to the controversy raised by Baumgartner and colleagues in 2022.
Right, their critique of the ESETT trial.
Exactly. For context, the ESETT trial was this massive study looking at second-line agents for established status epilepticus. But Baumgartner's group looked at how the first-line BZDs were given before patients were even enrolled in the trial.
And what is fascinating here is they essentially called out the entire methodology as flawed when applied specifically to toxic seizures.
Because of the underdosing.
Precisely. In the ESETT trial, The median cumulative dose of BZDs given before a patient was declared refractory and moved to a second-line agent was just 4.4 milligrams of lorazepam equivalents.
Which, for a patient with a known seizure disorder who just missed their medication, 4.4 milligrams might be a perfectly reasonable ceiling.
Sure, to test whether the seizure will break.
But 4.4 milligrams is a drop in the bucket if the patient's brain is currently bathing in a continuous supply of a chemical poison.
Right, because the toxin is actively competing against the endogenous GABA system. The pharmacodynamics of a toxic exposure just demand a completely different approach.
You're trying to chemically overwhelm a massive, sustained excitatory signal.
Exactly. And to be clear, we are just conveying the arguments made in the Baumgartner paper here.
Yeah.
But the toxicologists argue that you cannot arbitrarily cap your BZD dose at standard epilepsy levels.
You have to aggressively and continuously uptitrate the BZDs until the seizure stops.
Or until you secure the airway and induce a coma. You just keep pushing.
So the message is to push the BZDs far past standard comfort zones. But let's look at the clinical reality. Even with aggressive uptitration, sometimes those receptors have already internalized.
Yeah, or the toxic burden is just too high.
Right. The seizure continues, and the physician has to reach for a second-line therapy. And this is where the muscle memory of a standard dog can actually become actively harmful.
This is a huge trap.
Because you're probably wondering, wait, if we're talking about seizures, why haven't we mentioned the classic drug phenytoin?
Ah, the phenytoin dogma. This is exactly what medical toxicologists warn about. It's so deeply embedded in traditional algorithms.
But for toxicological seizures,
The literature is unambiguous. Phenytoin is practically useless, and in many specific overdose scenarios, it is profoundly dangerous.
to understand why phenytoin fails so badly, we have to look at its mechanism. It's deeply tied to its classification as a Class 1B antiarrhythmic agent, right?
Yes. In the heart, Class 1B agents bind to inactive sodium channels. They facilitate this rapid block and unblock, which reduces the refractory period without significantly prolonging the QRS complex on an EKG.
And in the central nervous system, phenytoin operates on a pretty similar principle. It binds to voltage-dependent sodium channels to stabilize them in their inactive state.
Right, to prevent the high-frequency repetitive firing of action potentials.
Which sounds great for stopping a seizure, but it relies on a huge assumption about the spatial nature of the seizure.
It assumes the seizure is focal.
Exactly. Phenytoin is designed to prevent a focal seizure from spreading. It's like a localized circuit breaker. If there's a power surge in the kitchen, the breaker flips, isolates the damage, and the rest of the house doesn't catch fire.
But a toxicological seizure is not a focal event originating in the kitchen.
Right.
The toxin is systemic. It's circulating in the bloodstream, crossing the blood-brain barrier globally. The entire electrical grid is surging simultaneously from the main transformer.
So a medication designed to build a firewall around a focal point does absolute nothing when the entire brain is saturated.
Nothing at all. And it gets worse than just being ineffective.
Yeah, if we look at specific toxidromes, giving phenytoin can cause catastrophic compounding effects. Take a patient seizing from an overdose of tricyclic antidepressants, or TCAs.
TCAs are notoriously potent sodium channel blockers on their own.
Right, which is why TCA overdoses typically present with a widened QRS interval on the EKG and severe arrhythmias.
So in that scenario, administering phenytoin means you are taking a patient who is actively dying from a massive sodium channel blockade.
And treating them by injecting another sodium channel blocker.
Exactly. You exacerbate the exact cellular toxicity you should be trying to mitigate. The cardiac consequences can be instantly fatal.
The sources also highlight a severe risk in cocaine-induced seizures, too.
Oh, definitely. Administering phenytoin in the presence of systemic cocaine toxicity has been tightly associated with sudden, life-threatening hypotension.
Total cardiovascular collapse.
Yeah, so we completely scrap phenytoin from the toxicological algorithm.
Which leaves us asking, what is the actual evidence-backed second-line agent?
Well, the most robust pharmacological rationale points to phenobarbital as the superior second-line agent.
Because it's a barbiturate, and the synergy with the BZDs we gave in the first line is just perfect.
It really is. Let's break that synergy down.
Okay, so we established earlier that BZDs increase the frequency of the chloride channels opening at the GABA receptor. Phenobarbital also acts on the GABA receptor, right?
Yeah. Yes, but at a completely different allosteric binding site.
And binding to that distinct site alters the channel kinetics differently.
Right. While BZDs make the channel open more frequently, phenobarbital increases the duration that the channel stays open.
Oh, I see. So going back to our club bouncer analogy, The
Yeah.
BZDs are making the bouncer open and close the door over and over really fast.
Yes.
But when you add phenobarbital, it just props the heavy door wide open so everyone can leave at once.
That is a brilliant way to visualize it. The combined effect is a massive, sustained influx of inhibitory chloride ions that just forces the neurons into a state of hyperpolarization.
It creates an overwhelming inhibitory tone.
It does. Very few toxins can overcome that.
Yeah.
But there's a physiological cost to locking those gates open.
Profound central nervous system depression.
Exactly. Phenobarbital almost universally leads to respiratory failure, meaning the patient has to be intubated and put on mechanical ventilation.
Which is why the sources also discuss propofol as a critical alternative for refractory cases, especially if the airway is already secured.
Yeah, propofol also exerts heavy GABAergic effects, but its pharmacokinetic profile is vastly different. It clears rapidly.
Because it's highly lipophilic, right. So once you stop the IV infusion, it leaves the central compartment really fast.
Which is its primary clinical advantage. It allows the care team to pause the sedation, perform a quick neurological wake-up test, and see if the underlying seizure has actually resolved.
Which you just cannot do quickly with phenobarbital. That can linger for days.
Right. But propofol isn't without its own severe risks. When pushed to the high doses needed to break a refractory toxic seizure, you run into the risk of PRES.
Propofol infusion syndrome.
Yeah, it's rare but highly lethal. The propofol interferes with the mitochondrial respiratory chain.
Inhibiting the oxidation of free fatty acids?
Exactly. And that leads to a catastrophic cascade severe metabolic acidosis, rhabdomyolysis, and fatal cardiac arrhythmias. So it requires intense monitoring.
So you can really see the dilemma you face here. The traditional safe drug, phenytoin, is useless and dangerous.
And the effective drugs, phenobarbital and propofol, require intubation, ICU admission, and carry huge risks.
Which perfectly explains why there's such a desperate search for newer, safer alternatives. And that leads us to the wildest card in the recent literature, levetiracetam.
Yeah, levetiracetam, often known as Keppra. It has completely transformed outpatient neurology because of its remarkably clean safety profile.
It doesn't cause the profound respiratory depression of the barbiturates, and it doesn't have the cardiac risks of the Class 1B agents.
And it has minimal drug-drug interactions.
Plus, its mechanism of action is entirely distinct from the whole GABAergic system we've been talking about.
Right, it doesn't modulate chloride channels at all. It binds to a synaptic vesicle glycoprotein called SV2A.
Okay, so SV2A is integral to vesicle exocytosis, meaning in a presynaptic neuron, excitatory neurotransmitters are packaged into these little vesicles.
Yes, and when an action potential arrives, those vesicles fuse with the cell membrane to release their chemical payload into the synapse.
To stimulate the next neuron.
Exactly. By binding to SV2A, levetiracetam modulates that fusion process, restricting the release of excitatory neurotransmitters during high-frequency firing.
It's such an elegant mechanism. Rather than stepping on the brain's heavy inhibitory brakes like phenobarbital, it just gently lifts the foot off the excitatory gas pedal.
Very well put. And if you look at the 2018 retrospective study by Lee and colleagues, that elegant mechanism seemed to translate into real clinical magic.
They reviewed 34 patients suffering from drug-induced seizures who were treated with levetiracetam, and the outcomes were striking.
A 79% overall success rate for returning those patients to their baseline neurological health.
And even more impressive, 0 obvious adverse drug effects. No respiratory collapse, no arrhythmias.
Right, so if you stop reading the literature in 2018, levetiracetam looks like the absolute holy grail for toxicological seizures.
But of course, you can't stop reading there. Here's where it gets really interesting. The narrative takes a sharp turn when we examine the 2022 post-hoc analysis of the ESETT trial by Coralic and their team.
Yes, so the main ESETT trial was a huge, rigorous study comparing phenytoin, valproate, and levetiracetam for BZD refractory status epilepticus.
But because it was a general trial, toxic seizures weren't the primary focus.
Right. But Coralic's team dug through that massive data set to isolate the 30 specific patients whose seizures were definitively caused by a toxic exposure.
And the high-level data from those 30 patients paints a very, very sobering picture.
It really highlights how violent toxic seizures are. Across the board, regardless of which of the 3 second-line agents was used, the success rate for stopping the seizure was only 42%.
Over half of these patients failed the second-line therapy entirely.
Yeah, they required progression to deeper anesthetic comas. And honestly, that 42% failure rate really reinforces Baumgartner's earlier point about aggressive first-line BZD dosing.
Right. Because once a toxic seizure escapes that initial 30-minute window and becomes refractory, standard doses of any second-line agent are just fighting a totally uphill battle against a disrupted chemical environment.
Exactly. But the true revelation in Correlix analysis isn't the overall failure rate. It's what happens when you stratify the data by the specific type of toxin.
Yes, the efficacy of levetiracetam completely diverges depending on whether the patient is seizing from alcohol withdrawal or from cocaine toxicity.
The split in the data is just wild. It proves you cannot treat all toxic seizures as a single disease state.
Okay, so let's look at the alcohol subset. In patients whose seizures were triggered by severe alcohol withdrawal, levetiracetam performed flawlessly.
A 100% success rate. 3 out of 3 patients.
But then you look at the patient seizing from cocaine toxicity and the drug failed completely. Levetiracetam only achieved seizure cessation in 1 out of 7 patients.
A 14% success rate.
So why does a drug work perfectly for one chemical insult and fail miserably for another?
Well, we have to look at the vastly different cellular pathologies of alcohol withdrawal versus a cocaine overdose. Let's examine alcohol first.
Okay. Chronic ethanol consumption acts as a continuous artificial depressant. It constantly enhances GABA receptor function.
And inhibits the excitatory NMDA glutamate receptors, yeah. So to maintain homeostasis, the brain actually adapts over time.
Right. It downregulates its own endogenous GABA system and heavily upregulates its excitatory glutamate receptors just to stay awake.
So when the patient suddenly stops drinking, that artificial depressant is removed. The brain is left with a severely weakened inhibitory system and a massive overabundance of excitatory pathways.
It's a purely structural imbalance. Weak brakes and a stuck gas pedal.
Precisely. It's an imbalance in receptor density. So because levetiracetam works by binding to SV2A and restricting the release of excitatory neurotransmitters, it directly targets that stuck gas pedal.
It modulates the excessive glutamate release.
Yeah, restoring a semblance of balance, which perfectly explains its high efficacy in the alcohol withdrawal subset.
But cocaine fundamentally alters the battlefield in a way that structural adaptation doesn't.
Right. Cocaine isn't just tweaking receptor densities over time. It causes an acute, violent blockade of monoamine reuptake transporters.
It acts primarily on the presynaptic reuptake pumps for dopamine, serotonin, and significantly norepinephrine.
Yes. Under normal conditions, after a neuron fires and releases norepinephrine into the synapse, those pumps quickly vacuum it back up to stop the signal.
But cocaine just blocks the vacuum.
It blocks the vacuum entirely.
The result is this massive cascading accumulation of catecholamines in the synaptic cleft. It is a true monoamine storm.
And when you think about levetiracetam trying to manage that storm, you immediately realize why it fails.
Because SV2A modulation is just a gentle restriction of vesicle release.
Yeah.
It is completely outmatched by an acute flood of norepinephrine.
The sheer volume of excitatory neurotransmitters lingering in the synapse just overrides the subtle modulation of levetiracetam.
It's like trying to stop a flood with a sponge.
Exactly. For a stimulant-induced catecholamine storm like a cocaine overdose, you cannot rely on nuanced vesicle regulation. You require the blunt force physiological trauma of massive GABAergic sedation to shut the entire system down.
You have to return to the heavy artillery.
Yeah. If aggressive escalating doses of BZDs fail, you need the profound synergy of phenobarbital to lock those chloride doors open.
Or the rapid systemic suppression of propofol, accepting the risks of intubation and ICU care just to save the brain from literally burning itself out.
This specific split in the Correlix data really emphasizes the core principle of medical toxicology. The treatment has to be tailored to the exact pharmacodynamics of the poison.
Right. A clean safety profile like levetiracetam's is completely irrelevant if the drug's mechanism is mismatched to the toxin's mechanism of injury.
If we connect this to the bigger picture, it completely reframes how we view emergency response. Treating a toxicological seizure isn't about treating an intrinsic brain disease.
The brain is just the substrate where the battle is happening.
Right. You cannot just aim to suppress the symptom, the electrical misfiring.
Yeah.
You have to understand the specific mechanism of the hostile chemical invader and neutralize it. You have to treat the poison.
And that philosophy forces clinicians to move away from rigid flowcharts and toward dynamic receptor-level problem solving.
It requires a deep understanding of neurochemistry in real time.
Which leaves you, the listener, with a final, pretty provocative thought heavily hinted at in the literature, pointing to the next frontier of this field.
Oh, this is a great point to bring up.
Yeah. We've spent this entire deep dive talking about either boosting the inhibitory GABA system or restricting the release of vesicles. But what about targeting the excitatory receptors directly?
Right. The sources discuss the emerging role of ketamine for super-refractory toxic seizures.
Ketamine introduces a completely different mechanism, right? It is an NMDA receptor antagonist.
Yes. Instead of trying to enhance the brain's inhibitory pathways, it directly binds to and blocks the excitatory glutamate receptors.
It just shuts down the excitatory floodgates themselves.
Exactly. If the toxin is causing a massive storm of excitatory signals, ketamine simply unplugs the receivers.
Could the future of treating these impossible refractory toxic seizures lie not in sedating the entire brain into a deep barbiturate coma, but in precisely targeting and blocking the specific excitatory receptors the toxins are abusing?
It's totally possible. The early data on NMDA antagonism is promising because it directly counters the excitatory neurotoxicity without the profound hemodynamic and respiratory depression associated with phenobarbital or high-dose propofol.
It's a fascinating frontier that proves how much we still have to learn. Because at the end of the day, when you step into the world of neurotoxicology, the clean, localized diagnostics of standard neurology are left behind.
The environment is chaotic, the chemical imbalances are profound, and the standard rules just do not apply.
But by breaking down the exact chemical nature of the storm, piece by piece, receptor by receptor, clinicians can learn how to finally turn the power back on safely. It's definitely something to ponder the next time you hear the phrase textbook medicine.